Welcome to VirtualClinic. I'm Dr. Ryan Bentley. Today I'm going to be discussing optimizing care and reducing the epidemic of preventable heart disease. As doctors, you had the privilege of making a positive impact on the health of many of your patients. Don't be haunted by the tragic stories where healthy changes came too late or never at all with your patients. Today you're going to learn how to implement predictive markers in your routine blood work to help prevent death and needless surgeries from falling upon your patients and their families. One disease may be caused by many factors, and one factor may cause many diseases. We have to ask ourselves this question as we're talking about cardiovascular disease, because there's over 40 million Americans taking a cholesterol-lowering drug right now, but yet heart disease is still the number one cause of death in America. And it has been for over 20 years, if not longer. So we really have to scrutinize this and say, what other factors come into play here with regards to heart disease that we're not looking at? It is important for us to recognize that traditional risk factors for coronary artery disease, such as smoking, hypertension, diabetes, and dyslipidemias, can only explain approximately 2/3 of the observed clinical events. Other factors and biochemical markers must be considered, such as high sensitivity C-reactive protein. And there are many others. Many experiencing cardiovascular events do not have well-recognized standard risk factors such as elevated cholesterol or hypertension. Thrombus, local or systemic inflammation, and chronic infection may play important roles in the initiation and progression of coronary heart disease. If you look at the Framingham study, which was a 26-year follow-up, 35% of the people with coronary heart disease occurred in people with total cholesterol levels below 200. So we have to go beyond cholesterol. We need to look at beyond just lipids, hypertension, and diabetes, but behavioral factors, hemostatic and thrombotic issues, inflammatory issues, and genetic issues. So I want to present to you a case. Doug presented to me after having 4 stents put in his heart because he had massive blockages in his heart going on. But no one paid attention and looked more in depth because Doug's cholesterol was 121. That's crazy. But yet we had to put in stents. So it tells us that cholesterol is not the issue with him. But nothing else was really assessed on him. They just put the stents in, put him on some medications, and that was it. But let me share with you something that was very key that I found in Doug's blood work. You can see here in Doug's blood work that his homocysteine level is 32.5. Greater than 15 is absolutely out of the clinical range by traditional standards. I'll make an argument later in this presentation that anything above 10 is a significant issue. So once I identified this with him, we went to work. And we'll talk about the mechanisms and what we did later on, but basically I put him on a B complex. And these are the results of his blood work on our last follow-up. You can see in our follow-up that his levels are at 13.1, which is not quite where we want it. However, it's definitely much better than where it was. So now let me explain to you why homocysteine can create cardiovascular disease. Homocysteine has been confirmed in many independent studies to be a risk factor for cardiovascular disease. The prevalence of hyperhomocysteemia is not insignificant. The general population is between 5 and 10%. In the elderly population, it is between 30 and 40%. And in patients with vascular disease, it's between 20 and 40%. Now, I have a theory as to why it is increased in the elderly populations. As we know, as the population gets older, our gastric acid production starts to go down, and that affects the absorption of B12. And that is something that can lead to hyperhomocysteemia in these patients. If you look at total homocysteine, as the number goes up down here along the bottom, the mortality ratio continues to rise. Anything here about roughly 12.5, you can see the mortality ratio goes above 1. That's not a good thing. And you can see in this study, as the homocysteine climbs from 8 to 20, that the percent of stenosis in the subjects increases. Homocysteine has atherothrombic properties. It causes intimal thickening, elastic lamina disruption, smooth muscle hypertrophy, marked platelet accumulation, platelet-enriched inclusive thrombi. Causes of hyperhomocysteemia are things such as genetic defects, such as the 5-methyltetrahydrofolate reductase enzyme. There can be a polymorphism that can lead to a disruption of the methylation processes. nutritional deficiencies such as vitamin B6, B12, and B9, also known as folic acid. There are medical conditions such as chronic renal failure that can lead to hyperhomocysteemia. Certain drugs such as methotrexate or trimethoprim, which also is composed in Bactrim. Other things such as niacin, bile acid sequestrants, phenytoin, theophylline, oral contraceptives, and proton pump inhibitors have all been linked to creating deficiencies of certain B vitamins or disrupting the methylation process, such as methotrexate and trimethoprim, which can lead to increased levels of homocysteine. And also smoking is shown to cause increased levels of homocysteine. It is estimated that 2/3 of the cases of hyperhomocysteemia is caused by a vitamin deficiency. Now the mechanism here comes into this methylation process. We have to have B12. We have to have folic acid. We also have to have B6 because homocysteine is an intermediate as part of going to methionine and SAMe in this whole cycle. However, homocysteine also comes down and becomes glutathione. So you see it takes B6 to get to this level of cysteine, which goes to the glutathione pathway. So homocysteine is a much needed amino acid in the body. However, it cannot stay at this level in high amounts. When homocysteine accumulates, it creates autooxidation, which leads to the generation of reactive oxygen species, which are free radicals, which causes lipid peroxidation, which will oxidize the LDL molecule, making it more readily available to be absorbed into the macrophages, creating foam cells, which leads to the atheroma development. Lipid peroxidation also damages the endothelium. This will cause a decrease in nitric oxide formation, which will therefore not allow the vessels to relax, changing the oxygenation. It decreases vasodilation, which will lead to hypertension, which also leads to atherosclerosis. And then also this damage to the endothelium causes exposure of the smooth muscle, which will allow it to proliferate and also create chemotaxis, which is an inflammatory immune response, which also helps generate the atheromas. Hyperhomocysteemia has been linked to myocardial infarction, acute coronary syndrome, premature coronary artery disease, cardiovascular mortality, total mortality, and as in the patient that I discussed earlier, Doug, he had 4 stents put in. That is what post-PCI is, percutaneous intervention. So it was never even measured in him. So you have more adverse outcomes when you have high levels of homocysteine. By running this test, we may have certainly saved his life. Coronary artery stenosis is also linked with high levels of homocysteine, stroke, recurrent stroke, and heart failure. Homocysteine elevation is also known to be strongly associated and linked to several medical conditions, including osteoporosis, cognitive impairment and decline, increased prenatal complications to women and unborn children, such as spina bifida. That is something that can happen as well when you have decreased folic acid, your methylation patterns change, chronic kidney disease, and other conditions. So the target goals of homocysteine levels and therapy is what we'll discuss next. If you look at this study, when it is below 9, your overall mortality is at 3.8%. However, when it goes between 9 and 14.9, it goes up to 9.9%. Between 15 and 19.9, it's up to 25.4%. Anything above 20, it's at 26.9% overall mortality. So everything gets worse as its homocysteine level starts to rise. You can look here in this study as well, is that anything below 9, the portion surviving remains stable. However, as it continues to elevate down here over the years with the different levels of homocysteine, there's a continuous decline in the amount of patients surviving. The therapeutic goal for homocysteine should be below 10, and that is also recommended by various medical authorities. The treatment recommendations for patients with hyperhomocysteemia is to add a B-complex vitamin containing at least the following B vitamins: at least 1 milligram of folic acid, 10 milligrams of B6, and 1 milligram of vitamin B12. The cost of these recommendations is very inexpensive. Folic acid at 1 milligram per day costs 3 cents. Vitamin B6 at 10 milligrams per day, 2 cents. Vitamin B12 at 1 milligram per day, that's 6 cents. That's a total cost of 11 cents per day to your patient. 11 cents times 30 days in a month, that equals $3.30 per month. That's equivocal to 1 tall latte at Starbucks per month. So to me, it's insane not to make these recommendations to your patients and not to be looking for this in your patients that have increased risk of heart disease. Not only are these recommendations very inexpensive, so is the blood test. In our portal, it costs $46 to run homocysteine on your patients. And if you're not running routine blood work on your patients, you should. Because not only is it beneficial for your patients to look at them as a whole person, to get a nice super panel to look at different parameters in their body, but it's also profitable to your practice. If we don't even look at markup of lab work, and if we just look at doing the report of findings, a report of findings is $195. That's what I charge. The average supplements for 3 months, not including just B6, but also other things because you find other factors going on with your patients, is roughly about $600 for 3 months. Lab follow-up is another $195. And a 12-week nutrition program, let's just say roughly $400. That's total revenue of $1,390. Take away your staff expense at $60, your materials at $5, and supplement cost at $300. Your total price of expenses is $365. Your total profit per case is $1,025. So my question to you is, how many cases per month can you do? How many can you do on an existing patient base that you have not already run routine blood work on? And what about all your new patients? If you do 10 cases per month, that is over $10,000 in additional revenue. How about 20 cases per month? That is over $20,000 of additional revenue in your practice by doing a report of findings. Now, if your state allows you to have markup on the labs, then certainly you can have an increased profitability with this process as well. But bottom line, doctors, is that what can be measured, can be monitored, can be managed. You need to manage your patients. You need to take care of them. Be a better doctor. Serve your patients well. Thank you for your time.